Now, it's the T-spine. We'll go over the basic terminology and some anatomy, but you will come to find out that all this is a collimated chest X-ray. That's all it is. Okay?
Yay.
You guys already know where the central ray should be directed. Where should central ray going to be directed for T-spine? T7, exactly. That's all it is. It's just a collimated chest X-ray. Okay?
Sweet.
So that should help alleviate some of the stress. Right? All right. So I'm just gonna fly through this. I just popped this up here again just for review, but you guys should be familiar with this right now. In the typical structure of a vertebrae. So I'm just gonna keep on going. I'll pause for a minute, maybe 10 seconds. Okay. Are you guys okay?
Yep.
Okay. This is all just a repeat. You guys okay?
Yeah.
Yep. All right. So the characteristics of a thoracic vertebrae. Number one, it has rib articulations. So the thoracic vertebrae is associated with your ribs, right? So if we've got 12 thoracic vertebrae, we should have what?
12 pairs.
12 ribs, okay? The articulation occurs in the areas where they have smooth surfaces called facets. Now, the rib articulates, especially 1 through 10. They have the costal transverse joint and you have the costal-vertebral joint. So the ribs are attached to two areas of the thoracic vertebrae. The articulation between the rib and the transverse process, that's your costal transverse joint.
So there's costotransverse
And there's costovertebral. Costotransverse and costovertebral. Okay? Now, do you guys recall rib anatomy? You guys recall that?
Mm-hmm.
Somewhat. It was what, last semester? So the costotransverse joint, the joint is formed by the tubercle of the rib and the transverse process of the thoracic vertebrae. The tubercle, okay, it's this rough surface on the rib. Okay, the tubercle of the rib. So the tubercle of the rib and the transverse process of the vertebrae forms the costal transverse joint. The costovertebral joint is formed by the head of the rib, and the body, of the thoracic vertebrae. Okay, so in the costotransverse joints, tubercle and the transverse process, again, you have these small surfaces known as facets. They're either full facets or they're half facets or demifacets or facets. T1 through T10, you have a full facet on T1. So if you look over here, you have a full facet on T1 on the upper part, on the upper body, and on the bottom body of T1, you have a demifacet. T2 to 3, 8, you have demifacets on the upper and lower bodies, T2 to T8. T9 has a demifacet on the upper body. And then T10 to T12, we have full facets. Now this looks a little bit confusing because I had nowhere else to put this, okay? This is referring to the costovertebral joint. So what's that joint?
Head and
The
vertebral
head of the
body.
rib and the body, okay, the body of the vertebrae. Okay. The other thing that's unique about the thoracic vertebrae is that the spinous process points down. If you recall on the cervical spinous process, it pointed outwardly. Thoracic vertebrae, the spinous process starts to point downward. Okay, any questions? I'm going to keep on going. No questions? Let's see what we have here. Facets, constant transverse joints. Okay, we already covered that part. There's a little blurb up there on the top right. I think it's also covered on this, I think. I'm sorry, let's go back over here. So the T1 to T4 looks very much similar like the cervical vertebrae, so it looks like a typical vertebrae, T1 to 4. T5 through T8 is your typical thoracic vertebrae. And then T9 through T12 starts to resemble a lumbar vertebrae. Now with that said, we said T1 to 4 looks like cervical, T5 through 8 is your typical thoracic, and then the rest of it going downward looks like your lumbar. So what does that tell you?
That they look alike.
No, they don't look alike.
Oh my god, are you mocking me?
Okay, so from the top to the bottom, it actually, so it's also getting, it goes from thin to thick. Okay? It goes from thin to thick. So it starts to increase in diameter as it makes its way downward as well.
Now why you were saying they look alike? Typical
They don't
thoracic.
look alike because this is typical cervical, this is typical thoracic,
Okay.
and this is typical lumbar. So they don't look alike.
I'm gonna rewind it later.
Okay, you can do that. All right. All right, so we've already covered this part. I'm gonna hold that up here for just a second. If you have any questions, please feel free to ask. So again, this just basically covers your costotransverse joints and your costovertebral joints. Okay, no questions? Okay. So here is a thoracic vertebrae. The structures are, again, very similar to that of typical vertebrae that we've covered in the past. So anteriorly, you've got the body. Off the body, you've got the pedicles, and then they flare out to the transverse processes, and then they come back in,
Lamina.
and then they form the spinous process. Okay. So again, the zygapophyseal joint is formed by the superior and inferior articulating surfaces. It also has notches. The superior and inferior notches is going to form the intervertebral foramina. Intervertebral foramina. All right, so let's talk about a little bit about positioning now. So one of the things that we're going to access in our radiographs is the zygapophyseal joints. Now, in the cervical spine, how are these zygapophyseal joints demonstrated? In a lateral, okay? In a T-spine, it's demonstrated in an oblique. Okay, it's demonstrated in an oblique. And the oblique is very, very subtle, very subtle. You know, we're used to 45-degree obliquities. This one is almost in a true lateral. So if you look up here, in a lateral position, okay, you're going to rotate your patient just about 20 degrees. Again, it's very slight. You can either do it posteriorly or you could do it anteriorly. Okay? If we do posteriorly like this, okay, we're looking at the side furthest away from the image receptor. The zygapophyseal joints furthest away from the image receptor. Okay? If you do it anteriorly, again this slide, now you're looking at these zygapophyseal joints that's closest to the image receptor. All right? So if this is considered an LPO, right? So if this is an LPO, which side are we looking at?
Right.
The right. And again, real slight. This is considered an RAO. So which one are we looking
Right.
at now? Looking at the right. Okay. Okay, so that's for the zygapophyseal joints. So LPO, we look at the right. RAO, we're looking at the left. Did I say that right?
So it's the same principle
No, I'm
as
sorry.
it was with
LPO, you're looking
cervical.
at the right. Yeah, LPO, you're looking at the right. RAO, you're looking at the right.
Right.
Sorry,
You are so right.
I am so right. Okay. Now, for the cervical spine, when we're evaluating the intervertebral foramina, which position is it? It's the oblique. So for the T-spine, it's lateral. You guys see what we just did here?
Reversed.
It's reversed. So C-spine and T-spine just swap places. All right? So for the intervertebral foramina, it's going to be a lateral projection. And this is also a good picture here because it does show you how it goes from thin to thick as it makes its way down. So typical cervical up here, thoracic here, and then typical vertebrae as it makes its way down the lower back. All right. So this chart here should be very, very helpful. All right. By now, you guys should know your landmarks.
Should.
Should. Okay, so please review your landmarks again, because we are going to use these landmarks for these positions. Okay. All right. What happened? You guys know what's going to happen, right?
Yeah, because we should.
I know, as you should. Did you guys see my slides yet?
Yeah.
You seen them? You seen this?
Yeah.
All right, know your landmarks.
Oh my gosh, I did not see that. That is hilarious. Oh my God.
This is what I wish I had. I wish.
I have a question. So why you didn't paste your head for the posterior view?
What happened?
Why you didn't paste your head for posterior view?
See, I'm glad I'm dark skinned because you can't see me blushing. All right, landmarks. Got it? All right, this is all. Guys, it's all review. All right, so let's go ahead and cover, again, this is going to be a short presentation, so let's go ahead and talk about the positions. 3 basic positions: AP, lateral, and oblique. That's it, okay? So the first one we're going to cover here is the lateral T-spine. Actually, we're not covering it yet. What they're showing you here is that with the T-spine, are you guys familiar with the anode heel effect? Okay, so in the anode heel effect, where is the beam less intense?
Close to anode.
By the shoulders.
Okay, so it's less intense in the anode, more intense
Cathode.
at the cathode, right? So this is where we're going to use the anode heel effect, especially when we're doing the T-spine. And I don't even know why they even mention this, because it doesn't require the patient to be moved in any unusual position at all. So when you place them typically how you would on a table, this is the proper position, making use of the anode heel effect. Okay, because it's less dense up here and less and more dense down in the bottom where it approaches the abdomen. So if we're looking at the lower part of the thoracic spine, that's where it gets more dense, and that's where it is more intense at the cathode side. Does that make sense? Okay. And the other thing that you want to use is a compensating filter. Okay. So in a compensating filter, it goes from thin to thick. So where would you place the thin part of the compensating filter? Towards the chest or the abdomen? The thin part. Towards the abdomen. Yeah, we want towards the abdomen because we want more penetration in the abdominal area. Okay, and less towards the upper chest. Okay, we'll talk about breathing technique here in just a moment. Because it is thoracic spine and not a chest x-ray. Chest x-ray, you're using higher KVs. Okay, why do we use higher KVs for the chest x-ray?
For grays, more contrast.
Okay, exactly, because we want, so higher KVs means a longer scale of contrast. Longer scale of contrast, we want a contrast, we want a gray that identifies the bone from the heart, from the lungs, from the liver. So there are more body parts. Okay, we want more grays. But now that we're only looking at the spine, we want higher contrast. So we're going to use lower KVs. Okie dokes. All right, so here is your APT spine. This can be done upright, it can be done on the table. Central ray is going to be directed at the level of T7. You guys already know this. How do we find T7 in an AP projection?
Put a fist to jugular notch.
Okay, so put your fist below the jugular notch.
Not through jugular notch,
Through the
next
notch.
to
Okay,
it.
so how many inches is that approximately?
4, 3.
3 to 4 inches, and that should take you at the level of T7. Okay? So that should take you at the level T7. Now what about our SID? Are we at 70 inches? Are we at 40 inches? Okay, it's not a chest x-ray per se. So are we using 72? We're using 40 inches, right? So 40 inch SID. Collimate to the area of the spine. There's no need for you to open up your image receptor to the full size. So approximately 7 by 17 would be appropriate. Breathing instruction, they're going to hold on expiration. Why?
To make spine flatter.
To make the spine flat?
Oh, yeah. A little bit, no? I'm just kidding.
That's okay. Okay, well, why expiration? Why can't we do it on inspiration?
It's gonna move.
Forget about the diaphragm.
Closing.
Someone said air. Where is the spine? The spine is between the lungs. So we're trying to get rid of the air. Okay? Because if you don't get rid of the air, you're going to end up with an image that's a little bit more dense, higher density. So we're trying to get rid of the air in the lungs as much as possible. And that's why they're showing you to do it this way, because you can expel more air in a supine position than you can standing up. Okay, so the X-ray is going to be done, exposure is going to be done on expiration. All right, so C7 to L1 should be demonstrated. Vertebral bodies are well penetrated with optimal exposure factors. Okay, that's it. Lateral T-spine. Lateral T-spine. So we're going to roll them up on their side. Does it matter if we're doing a left lateral or a right lateral? Does it matter? It doesn't matter. But why is it easier to do a left lateral? Yeah, because you can see the spine, exactly. It's practical, you can see the spine. Okay? So we're going to put our patient in a true lateral position. Again, they're going to lay on their side, arms in front of them, legs bent for balance. You want to stand at either end of the table to make sure that they are properly aligned with the table. It's important that you adjust the patient's back in accordance with the surface of the image receptor. So someone who has broad shoulders or wide hips, it may cause the back to sink or bow. Okay? So if the patient has wide hips, you want to place something underneath their hips to straighten out their back. Someone who has broad shoulders, after you prop them up, someone who has broad shoulders, it may require a 3 to 5 degree angulation cephalic to open up the joint space. Now, something else to take into consideration is to put one of those lead strips behind the back, because this is going to produce a lot of scatter radiation. And what does scatter radiation do to your radiographic image?
Obscures detail.
Okay, how does it obscure detail?
It creates fog.
Okay, it creates fog. Okay, we're looking at bone. We're trying to maintain high contrast. Okay, so if you have scatter radiation, you're going to lose that high contrast. Now, we've done a study the last couple of years where we tried to see if there was any difference in shooting a very thick anatomical part with and without a lead strip, and we found out that it was very, very minor, because now the DR system and the CR system has gotten so good, it cleans out a majority of that fog. Okay, and besides, I don't even think, do you guys have lead strips in your hospitals? Probably not. Probably not anymore. Okay. All right. So again, collimate to an area of 7 by 17. You don't need a lot of a field. You're going to center at the level of T7. Now, there is one correction. I think your slide said mid-coronal. Okay, I don't know how they got mid-coronal, because the spine is towards the back, not in the middle. It's towards the back. So this is taken directly out of your book. It says central ray perpendicular to the long axis of the thoracic spine. So you're just going to go slightly towards the posterior, towards the back. Okay, it's not mid-coronal. At the level of T7. Now, how do we find T7 in this position?
7 to 8 inches below
this. Do this.
Okay, yeah, so 7 to 8 inches below the jugular notch.
Not jugular notch. C7.
So the fist at the jugular notch. This is
How it's called?
shaka.
Shaka?
So 7 to 8 inches below the spinous process of C7. Okay, any questions here?
I need a second.
Leave it up? Okay.
Please. Thank you.
Okay, everybody good? All right, so T1 to L1 is demonstrated. Why can't we see C7? It says only T1 and T1 and L1. Why can't we see C7?
Size of image receptor doesn't allow us.
Because what?
I think also maybe size of image receptor wouldn't allow us to open it so much. No, it would.
Well, no, because look, no, you can get it, but why can't we see it? Shoulder. That's fine.
And if a
But
patient...
no, but I like your thought. Okay.
No, seriously, so you think we would be able to open so much to cover all T, to
It's-
cover L1 and to cover
It's
C?
in there, you just can't see it. All right, so lateral projection demonstrates the intervertebral foramina. Okay, so lateral projection demonstrates the intervertebral foramina. Now, something a little bit different with lateral T-spines, and you're going to see a couple of variations. One, you will see your technologist having the patient hold their breath. Okay, but the proper way of doing it is through breathing. Again, 4, 5, 6 second breathing technique. So you have them breathe during the exposure. And what's the whole purpose of breathing during the exposure? What are we trying to move? What are we-
Ribs. Ribs.
Lungs, what else?
Ribs.
The ribs. Yeah, the lungs and the ribs. So we're trying to blur the lungs and the ribs. Also, maybe part of the heart. Okay, so we want motion. So again, I tell you guys to do a breathing technique. Your book tells you to do a breathing technique, but you will see technologists doing either one of those. Okay, so don't be surprised. Also, Dr. F said you're doing it wrong. I hope you guys aren't doing that. No, okay.
Has anyone contacted you yet from,
Huh?
from the hospital?
Sometimes they will say something. Yeah. They will say something sometimes. You look a little scared. Doing something
No.
you're not supposed to be doing?
Yes, but that's not connected to mentioning your name.
All right, guys, and here's the oblique. So from the lateral, you're either going to oblique from 20 degrees either way, okay? So if it's a posterior oblique, again, we're looking at the side furthest away. If it's an anterior oblique like so, we're looking at the side closest to the image receptor, okay? So 70-degree obliquity, either direction. Central ray is going to be perpendicular to 2-7 and the mid-axillary plane. And so I gave you guys this. This didn't come from your book. I found this online because I never knew what the mid-axillary plane was in relation to the mid-coronal plane. And they're just off by maybe like a hair, like a half an inch. Okay? But you just, mid-axillary just looks at the point of arm attachment. That's all it is. Okay? And it's slightly posterior to the mid-coronal plane. Okay? Also done on expiration because we want to get as much of the air out of the lungs as possible. Could this be done in a breathing technique? Well, I've seen people do it. Okay, because you get something that looks like this. So breathing may help to blur out the ribs. But for test purposes, you're going to do it on what? On expiration. So AP is on expiration, oblique is on expiration, the lateral is going to be breathing technique. Okay. All right, any questions?
Great lecture.
That was it. So we have a quiz on this material next week. Okay, now before I have the officers come do their talk, I just want to remind you guys of a few things. We're on schedule for our field trip on the 8th. Okay, so we're usually done with class a few hours before we have to meet. So after we're done with class, I'm going to let you guys go out and do your own thing, and then we'll meet at the St. Jude's campus. Okay? Now, my advice, and I'm going to remind you of this again, you guys can go and do whatever you want. Okay? I'm not there to supervise you. You guys are adults, so you should know how you should present yourself when you come to the hospital. Okay? The other thing too is, and again, I'll bring this up later, I want you guys still need to keep your uniforms on. No baseball caps. Okay, can't wear your baseball caps. If you want to wear your hoodies, that's good, as long as, again, we are, because again, we're representing the school. Okay, and I need you guys to be at your best behavior, and I have this issue every year. I tell you guys to keep it down, remind yourselves where you are, and there's a tendency to forget where you are and they get rowdy. And guess who gets yelled at? Yeah, I get yelled at. Okay, so you got to remind yourselves where you are. There are very sick people there. And you have to be courteous, you have to be mindful. The other thing that I want you to remind you of is we are meeting there at 4:30. If I say to be there at 4:30, you need to be there at 4:30, not 4:35. Not 4:45. This happened a few years ago where the students showed up almost 25 minutes late. And it's not only rude, but it was an embarrassment, because these are staff members who are staying after hours. They're not getting paid for this, guys. They're staying after hours to sit down and tell you about what they do. You have to be courteous. Okay, so please show up on time, and I'll give you guys all the details of where to park and things like that next week. All right. Are there any questions?
Where is St. Jude?
St. Jude is over there.
Fullerton.
I'll give you the directions. Yeah, so you guys aren't actually going to park. You're not going to park at the main hospital. You're going to be parking across the street. And so again, I'll give you guys the map and the address and all that.
Cypress? What city is it?
in
It's Fullerton.
Yeah, Fullerton. I'm sorry, it's in Fullerton. Yes.
No, you answered it.
Yeah. All right. I can't remember. I'm sure there's other things I need to talk about, but I can't remember at this point. Okay. And we have lecture next week. Oh, so to prepare you guys for next week's field trip, I'm also going to do a presentation on the different modalities. Some of you guys may have heard this presentation before in my intro class, but I'm going to present it to you guys again to get yourself familiar with the modalities that you may be seeing that day. Okay? Yes? Oh, no, okay. All right.
So the field trip is next week?
It's going to be on the 8th.
On the 8th.
On the 8th. So next week I still have a lecture.
Okay.
The following week you'll have your field trip. And again, reminder, I think in the 15th, is it the 15th? Mr. Siegel, Mr. Siegel is going to be coming here to talk to you guys about your internship. Are you guys excited about that?
Yeah, buddy.
Yeah, working for free. So after they're done with the presentation, I still need to talk to you guys a little bit, okay?
Robinson, can I turn off?
You said you need the